Okay, so let's get started and we can let more people roll in as they come. So I'm going to talk just a little bit about futility in general to kind of introduce us all to what's out there already on this idea, and then we can kind of hone more into what futility means in interventional radiology. So to start, I thought it'd be helpful to talk about kind of the history of futility and where that word comes from, because I think it's interesting. So the word futility actually comes from the word futilis in Latin, which means leaky. And the reason why is because there was this Greek myth about the daughters of Danaus that had killed their husbands and were damned to fetch water with leaky sieves for the rest of their lives. And so the idea of futility came from that word, of this idea of these leaky pails with holes in it that you could never really fetch any water in. And so it's just an interesting origin of the word. And it actually has, futility in medicine has very deep roots. So even back to Hippocrates and Plato, they both commented on the idea of futility in medicine. So Hippocrates talked about that, there's an important time when we should stop treating people, that maybe there's a point in which we're not doing any good and maybe we're doing harm, going back to the idea of first doing no harm that also originated around that time. And Plato took this a bit further to say that, well, even if you might have alternative motives, and that even if your patient is as rich as Midas, that you shouldn't just treat them because they want you to treat them, that maybe there's some greater good that we should be serving as being stewards of medical resources and helping people, and that even if they're requesting it, maybe there's a point at which we shouldn't be treating people anymore. But a lot of the modern thoughts on futility really came out of the 1980s. So there was a long time in which this really wasn't a debated area that much, even though people kind of dealt with it on their own. What really brought it to a head and brought it out in the forefront of research, where you start seeing articles and people commenting on it, were CPR studies. So there were these big studies that initially showed that CPR wasn't half as effective as what we thought it was, that we kind of honed it as, wow, we can bring people back to life, but if you really look at the percent of people that walk out of the hospital, it was something like less than 20% originally. And so it started to bring up these questions about, like, well, what are we really doing? At what point is an intervention not worth it anymore and not really worth putting people through? Because as you know, CPR is not a subtle procedure. You're cracking ribs, you're injecting things into people, getting access, there's blood, needles. It's a pretty traumatic experience for people. And so it started to raise questions about, well, at what point do we say that something isn't worth it? And out of that kind of brought these two different definitions of futility that have broadly been called by ethicists as quantitative and qualitative futilities. The idea is, like, how do you really define something that's futile in medicine? And so the analytical left brain approach is to say that, well, maybe there's a percent that we should say is not worth it. And usually the percent that's thrown around is less than a 1 in 100 chance of it being successful. And usually that idea of success is based on a physiological success. So restoring some life, treating a disease, normalizing a white count, normalizing hemodynamics. It's very analytical. And the critique of that is that, one, the pro of it is that you have something more substantial that is very numerical and not subjective. On the other side of it is that, as I'm sure you know, it's hard in medicine to ever estimate for sure of something that's 1 in 100 chance. And, who knows what it is for this patient in particular. And on top of that, it completely takes out other parts of benefit. So it's not just physical benefit, but what about quality of life? What about, letting someone live that extra month to make their daughter's wedding or something, even if they weren't having a physiological benefit. So that brought in qualitative futility, which was, well, maybe what futility is that something is futile if it doesn't provide any benefit in the patient's eyes or in the patient's and the family's eyes. The pro of that is that it brings in all those other things like quality of life and physiologic benefit, feeling better, but at the same time, it then opens us up to then just be kind of that patient's hopes and whims in a way of that. It brings up that, well, maybe physicians should be stewards of these resources, and we shouldn't just do whatever people want us to do. And sometimes, especially at the end of life when emotions are high, that people, might think that they want their loved one to live longer, but they want them to live longer for themselves and not them. And how do you parse that out? And so people have continued even to this day to debate those two different extremes of qualitative and quantitative futility and what's the proper balance. And there really hasn't been a definitive answer to that question. And so the other thing that I wanted to talk about was, well, what about legal cases related to futility in medicine? And in general, the law has taken a rather paternalistic look at futility, meaning that the law, in order to practice medicine, you have to have a certain amount of skills, you have to be licensed. And because of that, the law has mainly taken the stance of that the person that determines whether something is futile or not is the physician, and it's only the physicians that get to make that determination. However, there are important exceptions to that, and I wanted to bring up 3 specific cases that I think might enrich our discussion. And so one is Inri Wingley in 1991. And this was in Minnesota, where this lady had received hip surgery and was on her way home from the nursing home in an ambulance, and then had a respiratory arrest. Her heart stopped, and she suffered severe anoxic brain injury and was in a persistent vegetative state on a respirator. They took her back to the hospital, and the physicians felt like, well, ventilator support is futile and we should remove her from the ventilator, that she's really not going to get any better, going back to more of that quantitative futility, that there's a far less than a 1 in 100 chance of her regaining any kind of meaningful brain function. The family disagreed and felt that physicians shouldn't play God, was the quote, and so it was brought to the courts. Unfortunately, she ended up passing away before this was decided, which is why it starts that prefix in the court case. It's not someone versus someone, is because the person already passed away, but it was still taken to court to kind of make a statement on, well, what's the proper balance here? And because of the way this was argued, it was argued much more about who gets to make surrogate decision-making. And in that case, the hospital was trying to say that Mr. Wingley, her husband, shouldn't be making that decision about whether someone gets the ventilator or not. And the court ended up siding more with the husband, only because he would be her rightful surrogate decision maker. He would know what she wanted, and because of some other cases in the 70s, like Cruzan, we let people make their own decisions for themselves, and we let them choose what medical interventions they want, whether it's a surrogate decision maker or the patient themselves. And so they ended up saying that, hey, hospital, you don't get to be someone's like surrogate decision maker. The husband gets to decide if they want a ventilator or not. So it wasn't really argued as a futility case per se, which is in contrast to this second one, which this case in 1998 took place in Louisiana. And similarly, the patient suffered a cardiac arrest, was comatose, end-stage renal disease, quadriplegic, and the physicians at the hospital said, hey, there's like a less than a 1% chance of recovery. We want to take her off the vent, get her off the feeding tube, and be made DNR, DNI. The family disagreed. The physicians at the hospital tried to get her transferred to another hospital. No hospital accepted. And ultimately, they took it to the ethics committee. The ethics committee sided with the hospitals, and so they took her off the ventilator, and she died anyways. And so the family sued the hospital and the physicians for malpractice, saying that, well, you killed my loved one. And in this case, it's it's important that they ended up siding with the physicians in the hospital because of what I was saying initially, that determinations of futility in the law mainly rests with physicians. So you can't really claim that if physicians have determined that something is futile and they act on that, that they are going, that it counts as malpractice. And this is an important contrast, right, to that first case where it was argued more on that idea of surrogate decision making. It's also this interesting contrast between the two. Of in the first one, you're asking permission to remove life support, and the courts basically said no, as opposed to asking forgiveness, in which case they're like, well, the physicians probably did what was right, which is an interesting contrast. And then the final point, the final case I want to bring up are the Baby K trials in the 1990s, 1994. And this is an important exception if you're familiar with the with EMTALA, which has to do with stabilizing people emergently. So in this case, this baby was born with anencephaly, and the parents kept bringing the baby to the hospital every time that the child stopped breathing. And they came again and again, and they would stabilize them and send them out, and then the child would stop breathing. Basically, the physicians felt like, hey, you know, with anencephaly, they're not going to live beyond a year most likely, and we shouldn't have to keep stabilizing them each time. Eventually, the child's going to die, and so we shouldn't have to do this again and again. And the courts basically said, because of EMTALA, you know, that's not true. You don't get to choose when someone shows up to your emergency room who you get to stabilize or not. You have to stabilize people. Where it becomes gray is how long you have to stabilize them. This is where the courts in this case kind of waffled a bit to say that, well, we're not really sure how long that lasts. So once you get someone into the hospital, do you have to like keep treating them indefinitely because you've stabilized them? Because in light of those other cases where doctors determine futility, that wouldn't be the case. But they said, well, we're not really going to say a certain amount of time where things become stabilization versus ongoing issues of futility, and that's a better case to be left up to Congress. And so that's essentially where we've been left, is we have these cases like this that kind of go in two different directions depending on how you argue it. If it's more about surrogate decision making, is it more about determinations of futility? And so I thought that's an interesting contrast, because I know we talk about things on the medical side, but the law often, we have a very nice relationship with the law between us and medicine, with trying to kind of argue out these sticky issues. And so I wanted to kind of let you know what the conversation had been over in that field as well. And so that kind of leads us to our discussion is, well, what about interventional radiology? The reason why I wanted to start doing these ethics and IR seminars is that, you know, I think unfortunately the way that ethics gets talked about a lot of times is in principalism is the theory, which is, you know, the 4 principles that you probably learned in medical school about autonomy, non-maleficence, beneficence, and justice. And it takes kind of a very rudimentary look at ethics and doesn't really help you apply it to your everyday life. We kind of talk about these sensational cases as ethics cases, but what about your everyday determinations? And my view of ethics is, you know, ethics is the collective values of a group. And so if we don't determine what our collective values are, we're kind of left to make these determinations on our own. And so I thought it'd be helpful to start looking at this one topic at a time, starting with futility, to say, well, what do we in interventional radiology's trainees and practicing interventional radiologists think about futility, and what does that mean to us as a specialty? What are the ethics of IR related to futility? And so I thought it'd be interesting to just have a discussion about that. And then to inform that discussion, I actually did this informal survey on Twitter and SIR Connect, where I basically asked people, like, what is futility to you? What are the most futile procedures in IR? And what came out of that, I had 68 responses, and there was a lot of diversity. So the type of things that people thought were futile, you can see here, you know, people could list more than one procedure, so that's why these numbers are more than 68. But G-tubes, biopsies and known cancer, biliary work, were kind of the most common things that people felt like brought up issues of futility for them. And there was a lot of diversity in the narratives about what people considered futile. And it brought up a lot of those things that we just talked about in literature between qualitative and quantitative futility, where some people took a very much more numerical approach. Other people felt like it rested more in the patient's and family's determination. And there were even two of those respondents that didn't believe that futility existed, which is an interesting argument that sometimes gets brought up in literature as well, of that, well, if you really have an in-depth communication between the physician and the family members and really get to understand each other and communicate well, then there should never be an issue of futility. I don't know if I necessarily believe that, but it is another common perception that's out there and also came out in this survey as well. One interesting thing that came out that I wanted to kind of highlight in some of the responses was I felt like sometimes the responses confused palliative interventions with futility, which was interesting to me, where people would say that, well, we do a lot of these things that aren't really going to prolong people's lives at all, even if it's going to make them more comfortable, and that seems very futile to me. And so that's interesting because I think most of the time in literature, we don't equate futility with palliative interventions, that just because something is palliative and making people have a better quality of life, that it doesn't necessarily make it a futile intervention if you're helping someone feel better. On the other side of that, though, maybe it's because IR is a more analytical field, and maybe we're taking, again, more of that like objective quantitative futility approach of saying that, well, something's futile if it doesn't provide a direct physiological benefit and extend life. So I thought that was an interesting perception. And the other thing that came out was how difficult it is to kind of parse these determinations out in the field of interventional radiology because of our consultant role, that by the time someone comes to interventional radiology and has been referred to us, they've already been convinced to some degree of the utility of the intervention. And so it's hard to really have a robust kind of goals of care discussion with people in our role. And that what is our proper role in this is that us having a conversation with referring providers, but then people brought up how, especially in private practice, they're reluctant to say, well, I think this is a futile intervention, because then maybe that person's not willing to refer patients to you in the future. They'll just refer them to someone else. And how do I walk that line between voicing something that, well, I don't think that this is really in the patient's best interest, but not kind of piss off my referring physicians? How do I have the conversations with patients if they've already been told, you need to go to interventional radiology to have this procedure because this is going to help you, and now you as an interventionalist don't believe that it would help them? How do you bridge that conversation with patients and providers? And a lot of the respondents said how much that they struggle with this on a daily basis. So I think for us, the interesting questions for us to discuss are kind of these about, well, how do we define futility within our culture in interventional radiology? How should we discuss it with people? How should we discuss it with patients and referring providers? But then also trainees, is there a role for this in residency programs? Is there a way that we should be having more of these discussions? How do we approach futility, both personally and as a specialty? So with that, maybe we can open it up. I think that I've made it so that anyone can talk if you just unmute yourself, and anyone who would like to start sharing kind of their feelings or experiences or things like that, we can see where the discussion leads us. So don't be shy, and who would like to start us off?
Well, I guess I can start us off. Thank you so much for that introduction. This is Vishesh Jain. I'm a medical student at Vanderbilt. Um, I think one thing, I guess, touching on the point that you raised about, palliative being equated with futility, um, I think often, we get pulled into this notion that the only goal worth considering is extension of life, when frankly most of the stuff that medicine does, both medically and surgically, is usually not extending life at all, but rather improving quality of life. Um, and so futility in that sense seems more like, is there an intervention that ostensibly one hopes to improve quality of life with, but actually won't in any kind of sustainable way? Um, so, for example, the family thinks that it'll improve their quality of life, but with your medical knowledge that no, it's not gonna. Um, and then from that kind of context, how do you have the discussion with the family? And so for me, it's super important when we're having conversations with both patients and trainees to be really clear about what the plan of care in the sense of what the goals of care are. Um, because only if you have that straight can you really have a meaningful conversation about whether the medical intervention you're talking about is worthwhile.
No, I agree. I think that, it kind of has to start with a good goals of care conversation, you providing kind of your medical expertise, the family and patient providing what their goals ultimately are, whether it is more qualitative or quantitative. But yeah, for me, I think that just because we're not extending life doesn't make something futile. I take more of that. I'm more on the qualitative side of the definition of futility myself, like you were saying.
Hey, Eric, it's Bob Ryu. This is great. I think it's a terrific presentation so far. I'm really looking forward to the discussion. Um, there are so many different avenues that we could take this conversation down. Um, I guess I'll contribute in a personal way, and maybe add my own perspectives, as a practicing IR. Um, I had a very sort of concrete sense of the use of gastrostomy tubes. It's sort of, I think, to some degree at least, reflected in your poll. Um, and it also, uh, as I learn about Cruzan and Shivo and some other relevant cases to this, that, G tubes are kind of, in a sense, maybe almost well, they're obviously a very controversial thing in certain circumstances, but there were the circumstances where we would find ourselves as IRs in very difficult situations. Like, do we really want to do this? And that's quite frankly what led me, and I'm sure a lot of other people, toward wanting to learn more about the ethical questions that arise as a result of these things.
Mm-hmm.
What recently changed my mind in pondering some of these things that are imponderable, um, is the fact that maybe I'm leaning towards the notion that there really isn't a futile procedure.
Mm.
I never thought I would say that, but I'm saying it now publicly in front of everybody. Somebody who, a year ago, I never would have made the statement, but after further reflection, I may be leaning that way. And the reason I say that is because I used to feel like IR always we were kind of the dumping ground. Like, it's too high risk for surgery, therefore IR should do something. And because they can do something that's lower risk, that justified, ethically us doing some intervention, despite the fact that we all knew it wasn't really going to help anything. It really was a futile procedure. Um, and we all found ourselves in that situation. But now, as I start to think about it, it's really not about the procedure, right? It's not about even the patient. I think it can be a lot more about social structure in a bigger sense. And what does that G tube mean to a different social context, as opposed to simply, this is a way to administer nutrition to somebody who's unable to do it for themselves.
Mm.
So anyway, I feel like my thinking on this is evolving in a way I never predicted. uh, as somebody who's done a lot of these cases and really felt conflicted in a lot of different ways, I find myself in a position now where I never thought I would think this way.
It's interesting. I feel like, right now I've been in the medical intensive care unit quite a bit over the last couple months. And I feel like I've had a lot of conversations with patients and family members where, whether it's like a big intracranial hemorrhage or something else, where we're kind of going down the path to say, do you want to let this person pass away now, kind of, and succumb to this acute injury, or do you want to go down the pathway of a G-tube and a trach and an extended care facility and everything else? And that being like a really pivotal fork in the road that I find myself having these conversations again, because it's like once you start going down the G-tube, trach, extended care facility route, it's a long route, and sometimes people are ready for that, but a lot of people choose that, to your end, and that, if you're not providing physiological benefit, maybe you're not even providing a quality of life, but are you providing something socially for that person's social structure by providing that, if they choose to go down that route? I do think that we have, the responsibility that when people have that fork in the road to kind of say, do you know what you're signing up for, in a way, is what I've found myself saying to people, is that, I know that you don't want to lose the person right now in this acute injury. You weren't expecting them to have this brain bleed, and everything has changed in the last week or so, and we can keep having this conversation. But once we go down this pathway, it's very hard to stop it. Once you're feeding someone mechanically, once you're breathing for them, it's much harder to remove care than it is to start that intervention. And I feel like IR is often at the brink of starting that intervention and kind of starting down that pathway. And it's been to your point, bringing up the social structure, I just feel like I've been in that conversation a lot recently, and thinking about myself as a future interventional radiologist am I going to keep having these discussions? And it sounds like I am, because a lot of people brought that up about G-tubes.
I think the fact that, a very fundamental question with regard to interventional radiologists having the conversation to begin with, that's a critical part of this. Oftentimes, as you pointed out, we don't have the occasion to, and we may have other conflicting reasons to not want to have that conversation, quite frankly. Certainly in my generation of being trained in IR, this was inconceivable. And, it's really only in the last, 10 years, I'd say, that we've gotten so involved in the care of oncologic patients that, we've started to have a longitudinal experience where we really can develop relationships that are long-term, where, it's not inconceivable, where it's a responsibility, quite frankly, to have those conversations and build the relationships where you can have a meaningful conversation. To your point about futility and when, in terms of care, it's interesting. I was talking to one ethicist here at the University of Colorado, and she was saying, whether you start a futile procedure or method of care, or whether you stop treatment that is futile, it feels different. Stopping something that's not working is okay, as opposed to not starting something that you don't know may or may not work. And even if it's a 1 in a million chance, right? It's like, it's Dumb and Dumber. So you're saying there's a chance. I mean, that's what families hear from you. Yep. And so it's much harder to walk away from that. And we always do it. We do it to ourselves to some degree. We say, well, 99.999% of the time it's not going to help. But, we always sort of dangle that butt out there, so to speak. And it's, it's hard. I could totally understand where a family hangs on that tiny little sliver of hope. And then, with regard to quality of life, that's, you all know, everyone knows, quality of life is a value judgment. Who are we to say what quality of life is for somebody else? And we also know that people who are severely disabled report much higher qualities of life than what we as able-bodied people think this disability will lead to. And so that's an important thing to keep in mind as you have these conversations, that, you have to be a little bit careful. Obviously, maybe the prognosis is horrible, whatever, in a certain circumstance where it's a terminal situation. But in another one, like somebody's had a stroke, it's very hard to walk away from that and say, it's going to be bad. Well, maybe it's bad because that's how you view it, but that's not necessarily universally true.
Well, that's a good point. Are there other thoughts out there? I don't want to dominate that. I could talk to Bob Ryu all day about this. I realize, though.
Sure. Well, I'll speak up here. This is Morgan McLucky. I'm a medical student from Indiana. Thank you for the discussion so far. I'm curious, perhaps especially from you, Dr. Yu, on what your perspectives are in terms of kind of balancing these quantitative values that patients have on what is or isn't futile and extending life versus the cost of some of these interventions and supporting people who the patients here, perhaps there's a chance, and however small it is, we want to kind of be doing everything, and on a whole, kind of how that cost impacts our system.
Yeah, that's a great question, Morgan. I also don't want to, dominate the conversation or talk too much. I think you raised an excellent point. That's with regard to, social justice. We have a responsibility as stewards of the healthcare system. We have to try and balance that with the needs of our patients and what's prudent, quote unquote, what's futile. It's absolutely part of this, and why it makes it so hard. I mean, think about ECMO. ECMO is like eternal life from a cardiopulmonary standpoint. There's limited amounts of ECMO. It's a very expensive therapy. It's only done in certain places. And once you're on it, if you don't respond to treatment or you don't get over that acute episode, who's going to stop it? And that, the dollars are just pouring out of the healthcare system in circumstances like that. I wish I knew the right answer.
Sure.
This is the ongoing conversation we're going to have, though, which is great.
Yeah.
Well, that's another interesting point. Bringing up the larger justice perspective of all this is, outside of the United States, there's usually like limited amounts of ventilators and things like that, where people are much more reserved about what they will extend mechanically when it comes to life than we are here. So it's interesting in that when we have things like ECMO and things like that, is, are we kind of spoiled into not making those decisions? Should we be more responsible on an economic perspective? But then it always makes us feel a little murky in medicine when we start bringing in the money perspective to say like, well, maybe you're not worth spending the millions of dollars on to keep you on ECMO. It's a tough conversation, but that's the conversations that we had before, actually, with organ donation. So when organ donation became a thing, there were these things called God committees, where it was kind of our first iteration of trying to figure out like, well, we have this life-extending thing that can help people. How do we decide who gets it and who doesn't? And I think it was like anonymous physicians and then community members that basically sat on this committee that was anonymous and made decisions on who got kidneys initially.
Well, what are your thoughts, Morgan? What do you, what's your leaning?
Yeah. Geez, I mean, it's definitely hard to answer. The concept of, I guess, rationing in healthcare is also one that comes up when we talk about healthcare systems, and how it was mentioned that other healthcare systems around the world perhaps have more limited or fixed resources, and there's a larger body who decides kind of who gets what. But yeah, I mean, I guess it's really tricky. Ultimately, I guess choosing to go on a treatment like that or to stop a treatment is really made through joint discussions with the care team and with the family, and like weighing what the benefits are with the cost and what the outlook is. And I suppose where you don't really reach kind of a stopping point together is maybe where some of these legal cases end up happening, where there really isn't a place that that the patients or the patient's families feel that they're um, kind of really they're really in agreement with the care team.
One thing that I wonder about in kind of these discussions that try to reach that place together, that sometimes, as you say, don't end up working out, is I think in Western culture, and especially in the US, have a pretty, let's say, unhealthy relationship with death.
Mm.
And I mean, that's part of why I think everyone in the hospital values palliative care so much, right? That they're experts at trying to help both us as physicians as well as patients and families reinterpret and re-understand that relationship as, something that's inevitable, but that's something that's just part of life, and that life continues without it, and indeed because of it. And I wonder, because of that, how much of these conversations that don't have a good end um, could be improved by more focus on um, that kind of what we consider palliative care as a domain. So, for example, if, let's say, surgeons and IR physicians were trained to have those kinds of palliative care discussions without having to consult palliative care because they can't talk to every patient, how would that change things? And then, if we say that the public in general has a poor relationship with death, is it medicine's responsibility to improve that as a field?
Yeah. I mean, I definitely think having those conversations early is everything in my limited experience, at least, is that if you can talk to the patient is best, but talk to the family before you're at that critical point of talking about kind of comfort care versus doing something more and whatnot is just everything. If you can extend that conversation over a few days, or if you could have it, ideally where the person's still well and have advanced directives that are in place. I feel like it makes such a difference, is that when things go poorly, at least the times when I've been in conversations went poorly, it was because no one had had the conversation at all. People had very different expectations of what was going on. And then all of a sudden we're at this critical point where the person's like coding and we're heading towards ECMO or something like that. And the family thought the person was going to walk out of the hospital the next day. And then no one had ever had that conversation with them, or at least they didn't remember ever having that conversation.
Right.
And I think your point is a really good one, of that maybe in training, since we deal with people at the end of life a lot in IR, if we were formally trained more to have these conversations with people, maybe when they have their first interaction with us, if maybe we could be that person that plants that seed and says, hey, what's your understanding of where this is going and what your prognosis is, what are your values? And at least, have a little 5-minute conversation. It doesn't have to be a long, in-depth thing.
Right.
really great ideas, and certainly relevant in the era of changing educational paradigms with regard to IR. Now's the time where we have an opportunity to identify areas within IR, or IR education, I should say, that can have pretty high impact on trainees going forward. This whole conversation made me think of a sort of funny thing that happened. It was 2010 or 2011. We had a symposium in Chicago when I was back in Northwestern, and it was all based on interventional oncology, and we invited residents and medical students from around Chicagoland, the Midwest, and we had great attendance, and we probably had 75, 80 kids in the room. It was great. And, we're talking about Y90, we're talking about TACE, we're talking, ablation, blah, blah, blah. And I remember standing in front of the group, and I think Riyadh Salem was giving me a talk or whatever. And I said, hey, Riyadh, I wanted to have this conversation in the room. I said, how do you tell a patient that what you're doing isn't working and they're going to die? And Lewandowski got so mad at me because he was like, dude, you're being Debbie Downer here. That's not what this is about. And he, I get it, right? We're trying to talk about things that are hopefully going to have a positive impact on people's lives, people's survival, et cetera. But at the end of the day, TACE, honestly, is a palliative therapy most of the time. We'd like to, we have those patients that we bridge to transplant, they have longer survival. But even then, you're talking, 70% at 10 years. What they have may well be an ultimately fatal condition, like life in general. And just broaching that topic was not, if we weren't going to have it in an interventional oncology symposium, when exactly are you supposed to have that conversation? When are we going to start to talk about this in a meaningful way, right? That we can start to educate ourselves about what, how does that conversation go? How do we elicit those critical values that are so important to understand and build the relationships we need to have in order to, make it really meaningful for patients and their families?
No, definitely. I mean, that's one of the things that I think inspired this conversation a lot as well, is that, even in specialties that you would expect to have more of these conversations, they don't really. Actually, especially specific ethics more or less doesn't exist, or only exists in very, very small areas. And I think that's unfortunate, because it makes, medical ethics in general is very broad, and it doesn't really hit home for us. And for us in IR, ethics in gynecology isn't really going to always apply to us, right? But we deal with very specific issues, but then we don't talk about them because they're kind of uncomfortable to talk about, or you're seen as a Debbie Downer or things like that. But that's why it was very refreshing in this survey. Was I was afraid, I didn't know how it would go to start conversations of ethics in IR. People would just roll their eyes and be like, oh, here we go. Or like, who wants to talk about futility in IR because everything works, right? But I got these really sincere, long responses about thank you for doing this. I'm a new attending, and I struggle with this constantly, and I would love if there was a forum that I could talk about it. So I was like, wow, maybe people really are struggling with this, and they just don't have a place that they feel like they can talk about it and see and get advice and share stories.
Well, Eric, there's no question you're onto something here. And I think, quite frankly, this would, I think, be a great plenary session at SIR for the SIR staff who happen to be listening right now. This is just such fertile ground. And while it's hard to do, I think, in a truly sort of, typical plenary didactic way, even putting ideas in front of people and acknowledge them, and sort of, your concerns are the concerns of everybody. I think that'd be meaningful. I think it's something, and whether there are other avenues for having these discussions that are maybe a little more, quiet, closed door conversations that people can contribute to, obviously, that's even better. But you're onto something here, and you know, I think this is great. You deserve a ton of credit for starting this conversation. You know, we just need to keep it going.
Well, thank you. I appreciate that. And we actually, the next topic is going to be conflicts of interest in interventional radiology is my next one, which is a little bit more difficult to do, but I think that it'll be interesting. I've already gotten some interesting responses to that survey about what people define as a conflict of interest, and there's a lot of like specific stories people give of like, well, this is a conflict of interest, but this isn't, and it's completely contradictory to like the next person. So stay tuned for that one. But what maybe some other people, I know we have some other people on the call that might be shy to share their opinions. So I'd love to hear from as many people as we can. This is very much like a Masters of Arts ethics class. And you sit around a table and then the professor calls on you and is like, well, you know, what do you think, Eric? And does anyone else have any experiences to share about futility or what you think about it? Or maybe someone that has more of the quantitative feeling of it. I feel like everyone that's talked has talked more about that qualitative side, about, you know, it's what's in how patients define utility as opposed to more of the very analytical side, which some people are more on that side of that. Well, this should be a much more of a physiological definition, and we need to have guidelines to say it's a 1 in 100% chance or 1 in 100 chance, and thus then you wouldn't do that if it met that criteria. Which has actually been trials, by the way, of people trying to do this in ICU settings, and it doesn't go well, is the punchline. That's okay. I mean, I think we've had a very good discussion. I think this is interesting and has definitely been informative for me as far as maybe trying to get something at a conference or presenting this as an idea to have on a larger forum that I think would be interesting to try out at the next SIR if possible.
To shift gears, if there's not other perspectives on this issue that we want to talk about. You'd mentioned earlier about this notion that IR as a consulting service often doesn't get to have the conversations we might want to have. That often by the time IR gets consulted, the decision's kind of already made. And I think it's an interesting question of, like, you know, we're talking about ethics in IR. How do we make for IR enough autonomy to exercise those ethics? Are there kind of creative ways that one might change the institutional structure to allow those conversations to happen, even as a consulting service still?
I mean, I've found it interesting. I study physician cultures and have been studying interventional radiologists as they make the transition from resident to fellow to attending for the last few years. And what's come up especially this last year, is that people bring up that exact point again and again, which is interesting because people didn't bring it up before. of that they're like, what makes a good IR is knowing not only how to do a procedure, but when not to do it, and how to say and how to have that conversation about when not to do it. And I found that fascinating, and I ask people to say more, but people usually don't have a lot more to say. So I wonder if there is a way that we could start having more of a conversation as a society around this topic of futility, of, well, what's the best way to have a conversation, or what's the best organizational structure that, you know, I mean, maybe it's more being a consultant service, right? Is that if other specialties saw us more the way that they saw general surgery, for instance, and consulted us for cholecystitis rather than to do a lap chole, it's a little bit different of a conversation, right? Is that you consult me for like biliary obstruction, and I say that, well, you know, like a biliary tube isn't really going to do much good here, is different than if you consult me to say, like, put in a biliary tube, and I say no. Like,
Yeah, that's really interesting. I hadn't noticed that difference.
I mean, I think that's a larger issue for us as a specialty, is how do we present ourselves more as a consultant service? Because I think that'll ease those conversations a little bit more, of that if people treat us less like radiologists where you're ordering a procedure, is it's harder to have that conversation then, because if they're ordering the procedure, they're already convinced that there's a utility in it, you know, of, you know, put in this IVC filter, or put in this tube, or declot this, like, dialysis work, as opposed to if it's like, well, this person has SVC syndrome, what can you offer them? It's a little bit more of a conversation. So then in the note in the conversation, you'd be like, well, I think this would be helpful, this wouldn't be helpful, or I don't really have anything that would really help this person. I just think the conversation would go a lot better if we got to that point as a society. I don't think we're quite there yet, but
Gosh, there's so much to mine in this this particular part of the conversation. I mean, in terms of, you know, we have to be prepared to take on that role, and then as we evolve as a specialty, and we get away from the proceduralist model that has existed for decades, and we become more of a consultant service, exactly along the lines that Eric's talking about. Yeah, that takes time. You know, this is not a new concept, and we've been talking about this for many, many years, and I think we're clearly making progress toward that end, but it's not tomorrow and it's not next week. It's going to take more time, especially as it diffuses out into culture and into the medical sort of microculture or ecosystem over time. But there was another point I was going to make. You know, that there's so many different contexts here of our own, you know, our own moral values, our ethics as a group, our cultural values as interventionalists, and then in the healthcare ecosystem, and then institutionally. And I had this thought the other day as I was having a conversation again with an ethicist at our hospital. I would ask you all, you know, I know everybody who's on this call has an ethics committee at their hospital, because you have to. That's actually a joint commission thing. You have no choice. And even if you don't have an existing, you know, sitting ethics committee, your hospital has access to somebody who will act as an ethics consultant. So if you're like a small community hospital somewhere and you can't have a sitting committee, you have to have some access to the ability to have an ethics consultation. I think it's a reflection of the hospital or institutional culture, to what extent the institution supports the ethics committee. And if someone were willing to do this study, where you actually looked at the dollar value of how much a hospital pays to support its ethics committee, like on a dollar per, I don't know, bed basis. If you had a 600 bed hospital, for example, and you know they support $500,000 a year, $600,000 a year, just to make the math easy. So how does that compare? And is it reflective of an institutional culture? And my argument obviously would be yes. I think if you spend less on ethics, it's telling somebody something that that's not a huge priority. Ethics committee, generally speaking, I think there are only a few places in the country where ethics committees or ethics consultations are actually billed to the patient, which is a whole nother conversation we could have, which is really interesting to think about. Like, who does the ethics committee serve? Who does an ethics consult serve? Does it really serve the patient? Does it serve the institution? Does it serve the care team, the physical therapists, the nurses, all the people who are taking care of that patient, the family? There's so many interested parties in that consultation. And yet, if you bill for it, presumably the patient is the one paying, and therefore should the ethics consultant then have a responsibility to act on the best interest, presumably, of the patient? Anyway, I'm getting way off topic here, but I think, think about that. Go to your hospital, figure it out, and see, because I really do think hospitals that are committed to ethics, that really make a strong commitment, that says so much about culture, I think. That's just my own 2 cents. I'll shut up now.
Well, it's an interesting point, and actually, as the last part of my ethics degree, we got formally trained in ethics consultation, and there's actually not a standardized training for ethics consultation right now. The American Society for Bioethics and Humanities is trying to make one, and if you're interested in this, you can actually dig into it a bit on their society website, but it's kind of the Wild West still, because the attention of bioethics in healthcare is actually very new. It's not that ethics is new in healthcare, but as being a formal idea of something that has value and adds value is only in the last couple decades that exists. And so we're still trying to figure out those questions, and people, I don't think, have figured out a good way of, like, do you build a patient? Do you build a hospital? Is the ethics consult supposed to be on, like, because the way I was trained is you're not supposed to be on anyone's side. But if the hospital's paying your bill, then there's kind of like a conflict of interest there, right? Like, it's a weird position to be in, I think. So, I mean, I do think it's interesting. I mean, I think it's interesting in IR as well, is that if you're advocating what's best for the patient, you'll probably do less procedures and thus have less RVUs, and depending on your reimbursement structure, maybe be paid less. And so there is possibly a conflict of interest there that I think is interesting, leading into ethics and IR conversation number 2.
Well, I look forward to it.
Well, does anyone else have anything else that they would like to say, or burning comments? Or if not, then, I really appreciate the conversation that we've had. I think this has been a great first run of ethics and IR, and we can keep having these conversations and maybe even have something at committee meetings in the future and make this into a part of our specialty.
I think that's a really
I couldn't
great
agree
idea.
more. Yeah,
Eric, I really appreciated it, giving me a lot to think about.
Yeah, great job, Eric. This is really a terrific idea. I really look forward to having more of these things.
Awesome. Well, then let's leave it at that then, and email me if you want to talk offline or anything else, and help me then advertise our next webinar. I'll get it cooking for our next topic, which will be conflicts of interest, which I know is especially hairy for interventional radiology, so we'll tread lightly. But I think it's important for us to talk about as a specialty that has a very, very close relationship with industry and medical devices and everything else. So we'll talk about that. And then probably our third topic that I want to do is tribalism, which is near to dear to my heart since that was my thesis. In IR in particularly, I think that we are very sensitive to the idea of turf wars in medicine and how do we collaborate versus compete and what's the right way to do that and what are the ethics of that, which, by the way, has never really been discussed at all on any forum. So I think that we could really be on the forefront of that as well as a specialty to say, what are the ethics of tribalism in healthcare?
Awesome.
Sounds awesome. Yeah.
Okay, well, thank you very much for everyone that joined us, and we'll conclude there. I really appreciate it.
Likewise. Thanks, guys. Good night.
Thank you. Good night.